I have just realized that I made a boo-boo. I misspelled council first. In the throughout the video, the council has been misspelled. Okay, so it's counseling. The council, that's like counseling, the verb, and I wrote it as council, like the city council. So sorry about that, and I hope you enjoy the rest of the video. It will be useful. Please don't focus on spelling mistakes. Okay. So bye for now.
So here and here. Okay, so let this go. Let me show you the screen now. Now I have unfortunately just removed my timer on the Zoom. Okay, Sidra.
Yeah.
Because that was that had some kind of I felt it was like acting like a virus, so I removed it. So which means that we'll do timer on my phone and you can do on yours. You have 2.5 minutes to make some, I tell people to make some bubbles. Okay. I've not written any information here. I'm not tried to make it like an exam question. Just wanting to see your approach. Okay. Here, what you will see. Okay. The MDT report, I'll tell you verbally here. Sidra, if you're focusing. Yeah. Shall I tell you? So the MDT would have said that.
I'm sorry for interruption. Actually, oncology part still left in my preparation.
Don't worry. It's not about your oncology. It's about your approach. If you're still happy to do it, otherwise we can see if who is it? Salma and we. Oh, Fatma is again gone. Okay, I thought Fatma was here. Okay, so we can offer it to Salma. Fatma seems like being very busy in her whatever she's doing. So bless her. Okay. So let me assure you, Sidra, first of all, it's not about, I'm not going to worry about what management are you telling me, okay? And I'm not going to ask you about the details of the surgery, okay? Yeah? Does that make sense? Yeah. So what I'm asking, what I will be asking you is that to show me the approach, okay? What's your approach in this, cancer vulva? She's a diagnosed case. She was informed that her case will be discussed in the Gynae oncology MDT, and then she will be sent an appointment so that she can come back and have a discussion about her management options, okay? Based on whatever the MDT has recommended, okay? Now, MDT has discussed and they have agreed that best option is chemoradiation, okay, because of the extent of the disease, okay, and they've said that the other option is surgical option, okay, but they've said that surgical option will be extensive and that can cause, lots of issues, okay. So, and being a candidate, you should be aware of if the surgery is extensive, that because it's extending into her back passage as well as her urethra, okay. So they are saying that surgery is going to be extensive, so the preferred treatment they've given is chemoradiation. Now, I am here. Let me give you a name here. I'll write down a name here when you're making your points, okay, in the first 2 minutes. And then I'll write down my name and age and you can start. I'll start the timer then, okay? So you have 2 minutes to think how you will be talking to me, okay? And what options you'll be giving me, all right?
Okay.
If you are unclear about anything, you can ask me, okay? And when you're ready in 2 minutes, you can just give me a shout. Right?
Yeah.
Okay.
I will be assessed in all domains.
You will be assessed in all domains. Yeah. And then all domains doesn't mean that you drag all the domains, okay? Just be very sensible about. So let me give you a tip before you start. If I say I'll mark you in information gathering, that doesn't mean that you spend 4 minutes taking history, okay? That only means if for all the stations, it's a universal rule that you will only get targeted history, okay? So that even when you are being assessed, you will take targeted history. Being assessed doesn't mean that you waste your time there. You are seen, you are being examined to be a good evolving consultant, okay? They want to see that you don't start asking history like medical students, okay? So you're not going to do that. What they want to see is that you are asking very relevant and targeted questions, Okay, right?
Yeah.
So even whether you are being assessed or not should really not make any difference. Okay, you should still do everything in a perfect way. Okay.
Yeah.
Okay, good. Go on then.
Should I start?
Okay, wait, give me a second. Let me start the timer. Okay. Before you start, I'm going to give you a tip. Okay, a couple of tips. Yeah.
Yeah.
You can start that. Please don't use the word water bag or bladder. Okay. Don't use these kind of stupid sounding terminologies. It's not water bag. Okay. It's bladder. People know what bladder is. If you were planning to use that, I've just saved you from a funny mistake. Okay. Got it?
Yeah. Till now, we are using the word waterwork or problem with the
Sorry.
waterworks. You can.
Waterworks is fine. Waterworks is fine. That we use. Okay. Waterworks is fine. But water bag is not fine for bladder.
Okay.
Okay.
Yeah.
It's not water bag. It's bladder.
Yeah. Got it.
Okay. So don't do that. I just saved you
Yeah.
from a very funny mistake if you were going to do that. And second thing is that it's a misconcept that you should not be using the word down below. It's a misconcept. We use it regularly. RCOG doesn't forbid. They are okay with that. Our patients say down below. More, like more than half the patients would use this word, and we use it with them. Okay, so down below is not a forbidden word. Don't try to worry about that. I keep hearing people saying, don't say down below, don't say pelvic area, say vagina. I mean, or especially ladies of this age, like, 70 or 65, or they don't like to say vagina. They prefer to say down below. Okay. So, and many be okay to say and many won't be okay to say. So it's absolutely fine. Okay. So there's no problem with that. The problem is with water bag. Okay. Or water pipe. Don't say water pipe or urethra.
Then we should use the word urethra.
You can, if you have to, you can use the word,
I actually recently learned this word, water pipe too.
Yeah, no. Bladder is bladder. And then you can say urethra. Urethra is the tube that brings you wee out of your
Sure, yeah.
bladder, okay, or your urine out of your bladder. So you can say that it's not water pipe, okay? That's so funny. Yeah, I mean, if there was a real UK patient, they'd be really thinking that, oh my God, which world are these doctors coming from? They'll think that, it must be donkeys in their country, like or everywhere, no cars or nothing, they think that there's some primitive people thinking of water pipe and water bag. So please don't say that, okay?
Okay. Maybe I make more funny mistakes in the stations. Forgive me all.
Well, okay. I have saved you, isn't it? Now
Yeah, yeah.
in our last session, we decided that we're not going to say things that are funny, foolish, and failing. Okay.
Yeah, yeah.
All right. So let's start now. So what
Yeah.
was my name? What was my name?
Jenny.
Jenny. Yeah. Okay. Yeah. All right. Okay. So you can start now.
Should I start? Yeah.
Yeah.
Hello, I am Dr. Sidra, one of doctors in the Gynae clinic today. May I check your name and age, please?
Hi, doctor. I'm Jenny Shaw and I'm 64.
Okay. How would you like me to call you?
Jenny is fine, doctor.
You can call me Sidra. So, Jenny, I have gathered from your notes that you are here today as you have been diagnosed as a case of carcinoma down below, and you have a discussion with the MDT, a multidisciplinary team of the specialist doctors and the
Okay,
staff.
let me stop and restart the timer. Okay, let me
Okay.
let me tell you just one thing. When I said that it's so perfectly okay to say down below, I didn't mean that you can't give her diagnosis to her. Okay, you can still say you've been diagnosed as cancer of vulva. Carcinoma is not the correct word. Please don't say carcinoma to the patient. Okay, that's a jargon.
Vulva can be used.
Vulva is fine,
Vulva.
absolutely. I didn't
Okay.
mean to stop you from saying her diagnosis. Okay, so it's
Okay.
cancer
Yeah.
vulva. She is aware of that, so that's absolutely fine. When I started, I meant that if you are talking and in between there's this term that you want to use, then it's absolutely
Yeah.
fine to say either that or that. I'm not saying that she's an old lady. Don't say vulva. I'm not saying that. I'm just saying that many of our old patients, they prefer to use down below, even young patients as well. So what I was trying to say was that it's not wrong. So those mentors or those, assistant mentors who are giving feedbacks in various groups and saying, please don't say down below, don't say, that's not correct. Okay, that we use down below a lot. So I didn't mean to discourage you. I meant to say that, and when it's about diagnosis, then give the correct word for the
Yeah,
diagnosis.
they usually know the diagnosis when they have been diagnosed.
Yeah, diagnosis, because we have talked a lot about that, and it's because it's
Yeah.
cancer. But don't say carcinoma, say cancer. Okay, so I'll restart your timer because it was right in the start. I thought I can save you from
Yeah, yeah.
doing this
Yeah.
mistake. Okay, so let's restart.
Yeah. Okay.
Okay.
Hello, I am Dr. Sidra, one of doctors in the Gynae clinic today. May I check your name and age, please?
Hi, doctor. I'm Jenny Shaw, and I'm 64.
How would you like me to call you?
Jenny is fine, doctor.
Thanks, Jenny. You can call me Sidra.
Thank you.
Jenny, I have gathered that you are here today as you have been diagnosed with the cancer of vulva. And now you have a meeting with the multidisciplinary team of the specialist staffs and specialist doctors, and we are here to discuss it. Is it right?
Doctor, yes, I didn't have the meeting. They had to discuss my case, and they said that you will call me for discussing the management. So I haven't met them.
Yeah. Okay. First of all, Jenny, I'm really sorry we are meeting in such a difficult situation. And
It's okay.
okay. So, Jenny, since we are meeting for the first time, is it okay for you if I ask you a few questions to know your condition in a more detail? Then I will discuss what multidisciplinary team has decided.
Sure,
What you say?
doctor. Yeah,
Okay.
whatever.
So, Jenny, can you tell me more about how you are coping with this condition?
Oh, what what do you expect, doctor? I'm not able to sleep properly. It's been very, very stressful on me and my My son and my daughter, they are quite
Yeah,
stressed
I
as
can
well. Yeah.
understand.
Mm.
Yeah, we are actually I let me assure you, we all here are to support you, and we will support you in every way. I will put you in contact with the counselors. They will surely help you regarding this.
Thank you.
So okay.
Yeah, thank you. That
So
would be helpful. Yeah.
and any problem till now with your water work or your opening of the bowels at this time?
No, doctor. No, nothing.
Any pain in down below?
Uh, Not really. No.
So, Jenny, can you tell me when you were, how you were diagnosed with this condition?
Doctor, I had lots of itching down below, lots of itching. So, and once I felt that there was something there, it felt different to my hand. And first I thought
Hmm.
maybe it's like, just sometimes just, I didn't care that much. So then when the itching gone very bad, then I went to my GP and he, you know,
And then
examined.
you were testing. Okay. And if you have your cervical smears up to dated and normal before, till now,
Yes, yeah, always it was normal.
when was your last period? When you stopped having periods?
It's years ago, doctor. It was like I think
Yeah,
13
I can.
years. Yeah,
Any episode of bleeding after your
never.
you stopped? Okay.
No, no.
Other than eating, any other complaint you felt? Like any
No, doctor.
changes in the skin? Ever
Uh,
used any treatment for that?
I think there were changes in the color of the skin. I thought that it's just because of itching and all that. So no, I didn't use anything on that. When my GP
Any
saw, he
skin?
said it looks
Yeah,
suspicious. So he didn't give me anything. He sent me straight away to the clinic for a biopsy.
yeah. You taken any creams for any skin condition before that?
No, doctor.
Okay. So, Jenny, have you any children?
I have two normal deliveries, no issues.
Okay. And are you with someone at the moment?
My husband, doctor.
Yeah. And are you, if this problem is affecting your sex life partner, uh, uh, like your sexual life, is it affecting?
Of course, doctor. Yes, it was okay. We weren't anyway that kind of you know. mm,
Any
we
effect on your
hardly ever do
relationship?
it. So
Yeah.
we were hardly ever doing it. It's like mm, uh,
Okay.
quite infrequent. So
Yeah.
and it's sex life is like it was almost non-existent really.
Is it due to this problem or
No,
like
since
a
my
lot?
menopause, it slowly it
You
just
don't feel,
has gone,
yeah, less
faded
in
away.
desire. Yeah.
Mm.
Uh, if you're following with your GP for any medical condition
Um,
like diabetes,
no, doctor, nothing.
okay, any family history of cancers like this or any this type of cancer or any other cancer?
No, no, nothing.
Okay, and any medicines you are taking right now?
No, doctor.
Allergic to any medicine?
No, doctor.
So, Jenny, do you smoke?
No,
Take alcohol?
no,
And pardon me, any recreational drugs?
no, doctor.
Okay, actually, we ask such a questions from all our patients. Okay,
Okay.
any, yeah, any operation on your tummy or down below?
No, doctor.
Fine. So, Jenny, are you aware of your weight to height ratio?
It's normal, I think.
Fine. What do you do, Jenny?
Mm, Nothing. I'm a retired person.
Yeah, and you live with your partner, and is he sportive?
Yes, very supportive. My husband.
Yeah. So, Jenny, I know you feel anxious and depressed in the last few weeks after the diagnosis of your this problem. Uh, we are here to support you. If you feel the need of counselor at this time,
Oh, okay, doctor. If you
yeah,
think.
I will put you in contact with the counselor so that they can help. So, Jenny, what you have just told me and what I have gathered from your notes is that you have been diagnosed with this condition from you were having initially the itching, and after which you went to the specialist doctors and you were diagnosed with this condition, the cancer of the vulva. I'm really sorry you have to face all these things, and now our specialist doctors have done a meeting to decide your treatment plan, and we are here to discuss these management plans. Is it right? Any
Yes.
other concern particular you want to tell me right now?
No, doctor.
Okay, so let me take you through the course of the management, how we will take care of you in a very better way, how we can alleviate the symptoms and your problems which are you are having right now. As you are having a some the cancer at a somewhat at a later stage, we have some options to get you relief from this. Like the one option is a chemo radiation. Have you ever heard the term of chemo radiation?
I have, doctor. I'm not fan of chemo radiation.
Yeah, in this some injections are need to be given
I
by
don't want. I don't want it.
yeah. I respect your wishes. Is it okay for you if I give you the implications related to this and the other option, the surgery which we can go? I will tell you the risk associated with the both. Okay.
Okay.
As a doctor, I may need to tell you all the risk and all the benefits associated with the both options. So
Okay.
if I can discuss with you, fine. The one option is the surgery. In your situation, the surgery may need to be done somewhat in a more extensive way. So surgery, let me tell you, Jenny, though it will remove all the affected part of your down below, but the problems are linked with the surgery itself. The problems are also there with the during the surgery associated with the anesthesia. There are the problems which you can get after the surgery. Like there are the problems as the surgery is going to be a somewhat more extensive. It can involve your the part of urethra. It can even involve your back passage, and in this way, your both functions
What's
may be
urethra, doctor?
affected. Yeah, it is actually the tube that by which the urine will be passed out. Okay,
Okay. Okay. Okay.
like okay. So the front passage it is, and the back passage is if the surgery involves this area, there is the problem with the opening of your bowels. uh, so in this way, your life, your these basic needs can get much affected. The other
Time is up.
the second option is the chemo radiation.
Okay, doctor. Your
Should
time
I
is up.
continue? Should I
Time
continue?
is up.
Okay. I'm much slow.
Okay. What did you do here? Does anyone want to try before I say what did Sidra do here?
Can I say?
Anyone wants to do it?
Yeah. Can
Who
I?
is it?
Salma.
Salma. Okay, Salma. You don't need 2 minutes. Sidra, so stay with us. Okay.
Yeah.
Okay. We'll have a feedback for you. And note what Salma says, and you have to note Salma's mistakes as well. Okay. And her good points as well. Please keep focusing.
Yeah.
So,
Okay. Okay, Salma. So you don't need 2 minutes. Yeah, Salma?
some only I want to know that that MDT meeting already decided that chemoradiotherapy is better for her than the surgical
MDT
management.
meeting has given their consensus of recommendations. Okay. The recommendations include that the preferred treatment for her is chemoradiation. They have mentioned that, that's because the surgical option is it involves extensive surgery because the cancer is advanced and is it's in the midline, and it's encroaching her anus and her urethra as well. So they are saying that that will be an extensive surgery. Okay, so this is their report.
Yeah.
Shall I start the timer, Salma?
Yes.
All right, there we go.
And your name is, what is
Jenny
the
Shaw.
question?
Jenny Shaw, 64.
Jenny shows.
Let me restart the timer. Wait. Okay. Yeah.
So I'll start from the starting, or I'll introduce myself, or I'll ask your name also.
You just start the way you start in the exam.
Okay.
Mhm.
Jenny Jones.
Jenny Shaw.
Jenny Shaw.
Start the
Sorry.
timer again. Okay.
Okay. Start. Hello, Jenny. How are you? How is your recovery after this operation?
Sorry, which operation, doctor?
You have the tissue sampling taken that you in your.
That was 10 days ago. There was not a problem.
Okay.
at all. Mm.
Right. Any change from the last visit with your that operation? Any change?
Change in what, doctor?
You have itchiness before, am I right?
No change, doctor.
Mm-hmm. So today you came to know about the MDT meeting, the what they suggest for you. Am I right?
Yes, I was given an appointment to come.
Mm-hmm. So do you have any idea? Anybody explained to you about this?
No, doctor, I'm here so that you can explain.
Mm-hmm. Do you want me to explain that the meeting
I want to
opinion?
know what the MDT has decided, doctor. I'm very stressed. I want to know what is it that they are saying about my management.
Mm-hmm. Actually, this MDT meeting, they decide for you that there is a two option. One is that chemo radiation, another one is surgical management. Okay, so the chemo radiation is better than the surgical
I don't
management.
want chemo radiation, doctor.
May I know that why you don't want?
Oh, I've seen people, they suffer so much after chemo radiation.
Mm-hmm. So what you saw, that what is your experience? Can you tell
Yeah,
me more?
doctor, my friend had it and she was suffering so much. She was in extreme pain and so much problems. She lost her hair and I couldn't even see her. It was terrible. Her family was so traumatized by all the effects of the the chemotherapy and the radiation. So yeah, I'm worried. I will not be one.
Mm-hmm. I'm sorry to hear about that, about your friend. So can you tell me that what is the reason she has taken this chemotherapy? What is
Yeah,
the
breast cancer, doctor.
Mm-hmm. Actually, all cancer treatment, it is not same, and also all chemotherapy, the medication also, it is not same. Okay.
Yeah,
Yeah.
but still, can't you just remove it with the surgery and that's it, really? We are already very worried.
Mm-hmm. So do you want me to explain that whatever they decide, then whatever decision you'll take, we'll try to support you, and I can discuss with my consultant also. He will explain you more about that. Then you can explain to him also. How does it sound?
Okay, doctor.
Yeah.
Oh,
So actually, this chemo radiation and surgical management, both option, the success rate and the it is same, but the better lifestyle will be on chemo radiation.
why is
Yeah.
that so?
Yeah, because the surgical management, there is a extensive surgery that it will affect most of the area down below. That means you may need the plastic surgery, and there is a increased risks of that scarring and increased risks of bleeding, pain. This is the frequent risks. Yeah. So may need to involve the specialist doctor later on that for this cosmetic surgery. Am I clear?
I'm not
Hello?
sure. I don't understand why extensive, what extensive surgery, why plastics. I don't understand what's that.
Because your cancer, this down below, it involves the bladder, and also it involves the that back passage. Okay, so that's why it needs when we'll do the surgery, yeah, so it involves most of the area, then it will be more scaring. So may need that the cosmetic surgery in later on, may need
Oh,
to involve the specialist doctor later on. Yeah.
oh, okay.
So that's why the better lifestyle will be with chemoradiation, as you are, that. But there is a risk also that there is a side effect with chemotherapy and radiotherapy. Do you want me to explain that?
Yes, please.
Yeah, so this radiation, there could be that the skin color change, there could be that narrowing of the vagina, there could be infection, also there could be inflammation of bowel and bladder, there could be frequency of urine. Yeah, so but if it is happened like narrowing of the vagina, there is also how we can treat you, there is an option also. Do you want me to explain?
Uh,
Yeah.
no, doctor, I don't.
Okay.
I
Yeah.
just
Also,
want to understand why, if that has problems and this has problems, why are you thinking that both the options have problems? You're saying.
yeah, but if we compare, then the chemoradiotherapy will be more better than if you compare the surgical management.
But you just said that surgery means that you will need to involve plastic surgeons. So what's the problem then? They can do their surgery as well then?
Yeah, but it will be, that, yeah, it is later on, not that it is must that will involve the plastic surgeon. Okay. And your lifestyle will be more comfortable with this chemoradiotherapy. But success
Doctor,
rate is,
I want that if you can do surgery and then I don't mind if you need to involve plastic surgeons. If you are saying that first they will have to remove this tumor and then they may need plastic surgeons, I don't mind that. I'm just very scared of the chemoradiation.
yeah. So, okay, I'll give you another appointment with my consultant. You can discuss with my consultant. Yeah. Okay. And in this situation, some may difficult to cope up and also to take decision. Okay. So I'll give you the support group and counselor contact details who will help you emotionally and to take decision as well.
I don't want emotional. My family is there, so I don't want that, doctor. I just want you to treat my cancer.
Yeah, sure. We'll treat the cancer. If you need, if you feel, then you can contact with them. Otherwise, it's up to you. Yeah.
Okay, sure, doctor, sure. Yeah.
Okay. Do you have any question?
Uh, when are you? What's next now?
Yeah. So I can explain you the chemotherapy also side effect, that there is a, you will get this sore eye, and also sore mouth, nausea, vomiting, and there could be that you hair fall, yeah, and numbness and tingling sensation in your uh, limb. Okay. So uh, I'm explaining to you all the information, then you can take a informed decision plan.
So what's next, doctor, from today? What's next? What am I going to do next?
Yeah. So now I inform you that about the MDT, that decision. You can take your time and discuss with your family member, and then let us know. Yeah, and I'll give you another appointment also with my consultant. You can discuss about that, whatever you like. What do you think?
Okay, doctor. Yeah. When do you want to give me the appointment with the consultant?
Yeah, we'll let you know. I'll inform my consultant. And then I will let you know. Yeah. Okay. As soon as possible.
Okay.
Yeah. I'll give you written information. You can go through and you can take your time. You don't need to decide now. Yeah.
Okay,
Okay.
doctor.
Thank you.
Okay. Thank you so much. Thank you, doctor. Okay. So we have 28 seconds remaining. Okay. Okay. How did it go, Salma?
I tried to satisfy, but I don't know.
Okay. Anyone else wanting to let me know how Salma did, and then we'll ask how Sidra did, and then we'll proceed from there. Any feedback from others, from Usha, Hafsa?
Can I try? Just this is tough station. I want to try.
Usha?
Yes.
Okay, Usha, let's give you a chance, and then yeah. Okay, then we'll start talking. Okay, sure. Are you ready? So the patient's name is Jenny Shaw. Yeah,
Jennifer.
Jenny Shaw.
Jenny Shaw. Okay.
64 years. You know what MDT has said, have you? I've
Okay.
just
Yes.
okay. Let me start the timer and wait. Okay, so let me know when you're ready. Are you ready?
I can do now. Just
Okay.
Jennifer. Okay. Hello, I'm Usha, one of the doctor in clinic today. Can I confirm your name, please?
Hi, doctor. I'm Jenny Shaw.
Jennifer, sorry to meet you in such a situation. How have you been doing since coping since we saw you last time?
Just very stressed, doctor. All of the family stressed, of course.
Do you have a good support at home?
Yes, doctor, my husband and my children.
That's good to know that. If you still need, we can provide you support, and we are, NHS.
Thank you. Thank you.
Okay. So, Jenny, I know you already know your condition, and any other problem you are facing since we saw you last time? Anything more itching, bleeding?
No, doctor, it's a lot of itching there. Lot of itching. That's it. My GP gave me some medicine to sleep in the night, so that because I wasn't able to sleep with itching.
Oh.
But he didn't give me anything to apply on it. He said that because it's
Yeah.
He said it's specialist thing. You guys will tell. So
yeah, I know it's difficult to sleep. So any other, so may I know a bit more about, apart from that, any other family member has any cancer in?
No, doctor, never.
Okay. And have you ever been pregnant before?
I have 2 children, doctor.
And may I know your cervical smear, they were up to date before you developed?
Yeah, never had any problems, doctor.
Any other medical problem which you were following?
No.
Okay.
I hardly ever went to GP.
And any reservation for blood transfusion if it requires in case?
No, doctor. Do you think I'll need blood?
Because the options they have given, that's why.
Okay.
Yeah.
No, I don't mind.
Okay. Is it okay if I examine you from down below to see any changes when we saw last time? Anything?
I was just examined last week when they
okay.
checked the wound. Yeah, they checked the wound of my biopsy.
So yeah, I know you are alone today. Do you want anyone to be with you?
Why, doctor? Why do you need someone?
No, just because I need to discuss so many things with you. If you want to, so
no, I'm okay, doctor. Please go ahead.
No, it's fine. So as you know, I understand you are here to discuss your management plan, whatever you are, decided by team. So actually, team has decided for you surgery and other option is chemo radiation. So do you have any preference in your mind?
Doctor, I don't want chemo radiation.
Okay. Okay. Yeah, we will inform you all the risk and benefit, and in the end, whatever you decide, we will respect your wishes. So may I know the particular reason why?
Just doctor, my friend had chemo radiation for her breast cancer, and she was in terrible state. I just don't want that. She wasn't able to eat or drink anything, and she was it was very, very bad, really.
Sorry to hear about your friend.
She used to say there is like thorns in her throat and in her tongue, and it was so dry, and so she was terrible, doctor. She was in a terrible
So
state.
sorry to hear about your friend. But let me explain you. Every person's body behave different way, and it's not necessary. Some people get more side effect with medicine. Some people get less, and some people may not get.
Okay, but still, doctor, I mean,
Yeah, I can. And because your cancer is advanced now, advanced stage, because it involves a lot of area down below. So if we do surgery, the team has decided quality of life is better with surgery. Better with chemo radiation, because surgery it involve lot of area to remove the cancer tissue. Yeah, and after that, if we remove the lot of area, we have to fill the area with other things. So filling the area with like involve a
doctor, it just feels like a small thing, when I feel it, it's not that big. It's very small.
yeah, you are feeling small, but the tissue sample tells the area the cancer is spread quite a big area surrounding structure, like your front wall or back wall. So if we do surgery, we need to remove all the area, and then we need to fill the gap with other skin grafting. And when we do the removal, after healing process, it make a scar,
Okay.
and then you will be difficult in passing urine, passing stool, and it will be difficulty for you.
Okay.
Yeah, and like a big surgery, recovery will be longer, and big surgery has a own complication like infection, bleeding, and injury. Other nerve can damage, so that may affect quite risky. That is
Okay.
why. Yeah, am I clear to you? However, yeah, nothing is without risk. Chemo radiation own risk, surgery in own risk, but surgery has got more risk. As you said, your friend has, yeah, I agree with you. Chemo radiation, the blister and sore eye and dry mouth and tummy upset, this kind of hair loss. So, but these risks are not, these are short time risk, these risks were for not longer. Yeah. And we will give you medicine to prevent these these risks. Yeah.
Okay.
So,
Okay.
so what do you think?
Doctor, what would you do if it was you?
Actually, my circumstances are completely different from your circumstances. So maybe, I decide, I mean, we can't decide for you. We are here to help you, inform you, and in the end, decision is yours.
Okay. Yeah.
Anything?
Okay, doctor. I don't know at the moment. What should I do?
Yes, but the treatment should be started as earlier as, because the within when we decide within 61 days, treatment should be started, because as you know, cancer already advanced, so as soon as possible.
61 days. So I have like 40 days to
No,
decide.
no. It's not exact. Exact time is not in my mind exactly, but I will let you know. But what we advise
But
you
you
as
think
soon
I
as
have a full month to decide at least, because
no, it's not a full month. Otherwise, your cancer will spread more. It's not a full month. I'm sorry. I will let you know. I will ask my consultant. At the moment, I don't remember exactly, but what I know as
but
soon.
do I have to decide right now, doctor?
No, right now, you can go and take advice from your family member, partner, and as soon as if it will be better for you, yeah, we will arrange for you. So we will involve. I will tell my consultant, and all the whatever you decide, we will let the team know so they can start.
Seems like a very difficult decision, doctor. It's not easy.
Yes, I can understand it. I can imagine it's a really difficult decision. So we will, in that situation, a support group, the people who have gone through the same condition, they will help you, and also counselor, they will help you to make your decision. Yeah.
Okay, yeah,
I
that
will
will
give you
help. I
written
think.
information about the chemo, radiation, and surgery. You can read more, and then you can decide. May help you.
That will be very,
And
yeah.
whatever we discuss, I'm sorry again to meet you in such situation. Whatever we discuss, we can document in your file, and we will share with your GP as well. Yeah.
Okay, sure, doctor. Yeah.
Is anything else I can do for you?
No, when will I see the consultant?
Yeah, as soon as I will inform my consultant, and as soon as you can see, surely next. Yeah. Thank you for your time.
Thank you, doctor. Thank you so much.
Thank you.
Okay. So, okay. So you are in time, 8 seconds over in my. Okay. How was it, Usha?
I don't know. I did not prepare for long.
No, nobody prepared. None of these
Yeah,
girls knew
just
the.
I know. Yeah, but
It's your exam now.
yeah.
In few days, I won't even say weeks now. Start counting days. It's not weeks. Okay.
I know. I
It's
just
your exam.
whatever I.
You guys need to be all the times ready, ever ready. Okay. Yeah. Okay, so let's start with how it went. Okay, thanks for trying, everyone. Okay, Sidra and Salma and
Thank you for
Sidra.
giving opportunity. Just
You're very
want to
welcome.
speak something because it's just want to speak to get fear off.
Yeah. No, it's a very good idea, and it's good to be brave enough, because that will help you in the exam.
Yeah.
Power to speak is a good, attribute, because it helps them. Okay.
Thank you.
So I won't give you give you guys an itemized list of 20 items. I'll just focus on the big elephants in the room. Okay. So that you know where you could have done what. So for Sidra, are you here, Sidra? Are
Yeah,
you here, Sidra?
yeah.
I want you to be not on mute now. Okay. So
Yeah.
Sidra, so what was your elephant in the room? Did you realize that was something very big there? Salma, you remember any big thing that Sidra did? Like the biggest one you think she did?
Mistake, the biggest mistake, you mean?
Of course. I'll
Time
reward you
management,
later.
firstly.
Hmm?
Time management.
Oh,
First thing
8
is
minutes?
the main thing I should focus. History, I should
8
concise to 4 minutes.
minutes, Sidra,
Yeah.
8 minutes. Okay. You took 8 minutes in your, chit chat, really, not coming to the point.
Yeah.
8 minutes for just your information gathering, introduction, and all that. Okay. So that's like a lethal mistake.
Very little, very little.
Yeah, it's lethal. It's lethal. It's suicidal. Okay. So please,
Yeah.
despite that, I really liked the start. Like, your introduction was very empathetic and, very, I'd say, methodical. Okay. You you thought that at one point, I thought that I think she doesn't even remember that she needs to tell me the management. Okay. When 8 minutes were, I said, no, she's forgotten the station. She doesn't know what the station is. Okay. So please, girls, this is like one station that you had, just one. When you are in a sequence of 14 stations, the stress levels will be much, much, sky high. Okay. So you need to, this is not the time that I'd say, oh, train yourself, because now you need to have a stick in your hand all the times and, just hit on your back that, what have I done? Okay, because now is not the time to really, really enjoy any lovey-dovey feedback. Okay, this is not the time for lovey-dovey feedback at all. Okay. All right. You have to be harsh with yourself, bit cruel to yourself if you have to. That I don't mind that, but please, it's only few days an exam. If this is what you're doing now, and with such a person who is absolutely giving you no stress, I stopped you 3 times, Sidra, right in the start, just to make sure, like I stopped you once, but before that I said, don't do this mistake, don't do this mistake. And then I stopped you in the start and said, relax, don't do this, we'll start again. So you see that I was very, very, wanting you not to do mistakes, supporting you. Okay. You see, I was supporting you. Yeah. So that was cheating, but I was doing it. I said, nah, cheating is fine. I mean, I want you to come out with your best. Okay. But what you did was you went too relaxed and you just went on and on with your history. Now, do you think what was the bad part in the history? Did I not use the word targeted history? When you asked me, will I be assessed on all the, domains? I said, yes, but I immediately explained that your history still needs to be targeted. Did I say that?
Yeah.
What's the place of a history of 8 minutes in OSCE stations? There's no place. Okay, never. Okay, even if this station is only about information gathering. Okay, even then, don't do that. Okay, please. So there were, there were lots of things. I'll just quickly go about just a few. In the history, you are asking about smoking history, alcohol.
Yeah.
Okay, that's a waste. You have to understand, please bring in your mind that if this is a patient who came, through her GP, she was seen once, somebody would have taken her history. This is not her concern at this point. This is her almost 3rd appointment in a row with you guys. First, she came because she was referred and somebody took the biopsy. Then she, came afterwards when she was informed that the biopsy result is this and we have sent it to MDT. There will be a discussion and we'll soon call you. So this is her 3rd. And when she came for the 2nd visit, somebody would have examined her wound as well. That would be anyway tiny, 1 stitch there. It's not going to be like, it's not a major operation. So I'm thinking of Salma's words and on operation. Okay. So you need to understand that why on 3rd visit you are asking about, and why is it relevant? Smoking, does she smoke, alcohol? And please, don't say this sentence to people that I'm asking this question because we ask everybody. Because especially not asking drug history to a 64-year-old lady, that's actually quite an ignorance. Okay. I would ask drugs history to someone who, is pregnant and I want to know whether there are effects on the baby. I would ask in anyone who is maybe younger than 40, coming with even PMS or even bladder pain syndrome or anything. Under 40, I feel it's justified. Over 40, it's not a crime to ask, but here it was absolutely not relevant. Okay. Here, this was absolutely not relevant. I am telling you my trick and tip. Okay. That I don't ask. Over 40, if the patient is not pregnant, if the patient is not coming with PMS or bladder pain syndrome, where I have to make some connections, what could be the cause of, what's happening? I may ask something like that. But once the patient crosses 45, hardly any condition where I would need to link it with the drugs. You always need to justify your question. You always need to link it. Why are you asking? Okay.
Yeah, yeah.
See, so there was absolutely no reason to ask about drugs. And when I looked like this, you said, oh, this is a question we ask everyone. So that makes you, that doesn't make you smart. That makes you, I want to use the word opposite of smart. Okay.
Yeah.
Okay. So that makes you opposite of smart. That makes you foolish. Okay. And we talked in our last session. I didn't see you there. You might not have been aware of the session, but we said that we will not be saying things that are funny, foolish, or failing. Okay. So please don't say this sentence asking a 64-year-old woman about drugs. Okay.
Yeah.
And then saying we ask everyone. Okay. So
Yeah.
then what did you do? I'll give you a tip that I know it's something that will probably score you higher for, they'll make you look very smart. It will, I don't know how much will it be counted as a mistake or not. But when I'm telling you about the sexual history that we're hardly ever doing it. And you actually explored that. And I thought, oh, she's an intelligent girl. She's going to grab that, so you didn't. You explored a lot, but you didn't do anything about it. Okay. So what was it that you did? You asked me sexual history. I said, since the menopause, we hardly do it. Okay. So what do you think is the problem here? You have to go with the
Loss of libido, actually.
Huh?
Menopause, loss of libido associated with menopause.
Yeah. So you have a holistic approach. Okay.
Yeah.
Say once this thing is sorted, then we'll look into this. If we are able to help you with this as well, okay, please do either see your GP to discuss this, because there could be, and we could advise that you could use lubricants. We are going to assess her whether she's okay for estrogen cream or something, and because she would, if you explore, there would be libido, loss of libido, and dryness as well. You didn't ask dryness. I didn't say then dryness. Okay. Yeah. So then you will say that as well. But if I'm not saying that in exam station, this patient has this problem, I just added this here. Okay.
Yeah.
This is a situation in another station and it can come. Okay. So you need to be ready with how you approach. And RCOG is allowed to change their questions, aren't they? So they can add it. Okay. So please, when you are saying then loss of libido, you can say that, okay, there is an option of, some kind of HRT as well, but that will be, you are not going to be an expert there. You are getting treatment for cancer. I don't know whether we can just say that will be something that can be discussed with you once you have, once you are out of this current, palaver. Okay. All right. So there are options. You'll assure her that there are options, and we would talk. We would encourage you to have a meeting with either one of us or the menopausal clinic. They can help with or I'll talk to your GP. He may refer you to the menopause clinic, and they can advise you on an appropriate, treatment for this. Yeah. Okay. Yeah. Right. Okay. So that was something that I told you, and you didn't do anything about it. Then if I tell you that BMI is high, then you do something about it there and then move. But I said it's normal. Then I said, I don't want chemoradiation. And you didn't ask me why. Okay.
Yeah, that was, yeah.
Okay. That's very important. Okay. Somebody says me something.
I was interrupting. I felt like I should not, like you say, I should not focus on just describing each option to the patient. I should firstly address the concern of the patient at that moment. That was the mistake.
You did it probably because you then looked at your watch and you knew that
I should at least speak options to the patient.
Absolutely. So you please keep your history to a maximum of 2.5 minutes in this patient. In other patients, up to 3/4 to 4 minutes or 4 minutes is fine. In this patient, never exceed 2.5. I mean, I only asked 2 questions and I attempted all this. It was not this station, it was another oncology station, but I spent no time in history, like 40 seconds in history, asked 2 questions and moved on to the management, okay, to the rest of the station, okay. So history is, you have to be confident that whatever I later on feel that something is missing, I'll ask, okay. They won't be, you know, they're not going to punish you that why are you asking now, okay. So quickly jump, quickly. So this is my phrase. This is my phrase that I give to people, that quickly get down to the business, okay? Get down to the business, quickly, okay? So when they send you a patient, remember all girls, Rajni, Fatima, Hafsa, Salma, Usha, all of you, okay? Remember, please. When they have sent you a patient, without, you know, just with the condition that you have to explore, like you have to take history, they've sent you with symptoms, or they've sent you with, you know, existing diagnoses, like they're saying that this is a patient who suffers from epilepsy and she wants to conceive. So you have a diagnosis and you have, you know, but you haven't got any further details, you don't have any test results, and you don't have any, you know, further management or something, then you are okay to ask history and, you know, spend 4 minutes in history. But if they have already given either the diagnosis, okay, or they have given investigations, then please start right from those things and move on, okay.
Yeah.
See, so at that, in that one, it's not really fair. You need to understand that this is the starting point that they've given us. This is not that we have to, you know, I'm missing Manikam today because she is very good in remembering what I say. So I always say, please don't go back. If you are going back, then you are doing those same.
Good evening, ma'am.
Sorry?
Just now I have joined, ma'am.
You have
Good evening,
joined
ma'am.
just now. Why can I not see your name?
Ma'am? Now only I looked at, ma'am.
Are you on the Telegram? Ah, you are here. Okay. You're not on the Zoom, so that's why I didn't see. Yeah. Okay.
Just now, ma'am. Thank you.
Thank you, Manikam. So yeah, absolutely. So Manikam, I was just, look, I didn't even know that you were there and I was missing you. Okay. So you see that you need to remember the tips that I give you, or anybody gives you, if they are good tips, okay? Remember those. So try not to go back. If you go back, then it means that you actually, the main purpose of the station you have left to deal with maybe in the middle of the station or towards the end of the station. And actually that was the point where your station should have started, because most of the marks are in front of it, not behind it, okay? Most of the marks are subsequent to that thing that they have told you. So if you go back, then you are just wasting your time. Did you get my point, Sidra?
Yeah.
Okay,
Thank
so
you.
no need to go back, and no need to dig, you know, the history there. We're not, you know, sitting on History Channel. We have to do our station, and we have to get down to the business as soon as we look. And I keep saying to people that, listen, when I see something like that, I immediately, you know, I'm very happy. I say, okay, they've given me a starting point, right?
Yeah.
Okay, so when they've given you a starting point, then be happy and move on, please. Okay, so now, yeah, so I think, yeah, these were most of the problems that you then didn't have much time to explain. Okay. In your management, I'll talk when I discuss Salma's and Usha's, and you will get the points what you were wanting, you should have said in the management part, okay?
Yeah.
Now, let's come to Salma. So Salma, are you still here? Yeah?
Yes.
Hey, I see Poonam here. Poonam, you passed your exam, didn't you? No, I think I'm thinking of somebody else. Okay, sorry. So, okay, so Salma, what did you do? Can somebody say what did Salma do? What was Salma's big mistake? I'm so sorry, girls. I always ask what was the big mistake.
Yes.
I don't say what was the best thing. We'll talk about the best things as well.
I can say that I didn't history as much when you told me that to explain the
That's
meeting.
fine. That's not a big mistake. You know, I love not taking much history, so that was fine. Anyone else knows that what Salma did? What was the big mistake?
She
Anyone
didn't. She didn't have a plan of management of the patient. She kept telling the patient that she would link her to the consultant. The consultant will re-explain. She didn't. The patient came, but the patient was not really convinced, and she didn't give her the likely time she would start treatment and all those things. And she kept referring back to coming to see the consultant.
Yeah, absolutely. Is this Hafsa? Yeah.
Yes, yes.
Yeah, Hafsa. So I tell Salma why, because Salma has tried. In Salma's heart, she's thinking that what are you talking about? I've tried, and I know that she tried, but I'll tell you what happened there. I'll just come to this one, that what went wrong. But before that, she did a mistake. There was almost no introduction and no agenda. Okay, and that is a very poor start. Okay, Salma, do you remember what did you say?
Yeah, actually, Sam, I couldn't understand. I was thinking that you told that only management plan, so I just directly start. So that's why I did.
I said that go as in you, just as you would do in your station. Start your station, I said. Okay, so if that was a misunderstanding, then that's fine. All I want to be sure is that in the exam you are going in and you are doing a proper introduction.
Because Sidra already done, so I was thinking that only management plan.
Yeah. And because I sometimes do these things, you know, I say that ignore the introduction part and all that. So you thought I'm, you know, doing that. Yeah. Okay, I get your point. Okay. So I thought that how come Salma missed introduction? There's
no. I didn't go through like complete the station. I was thinking just you will give me few minutes just to explain the management plan.
Okay. No, that's fine. That's fine then. In the exam, you will know that you have to cover. So I should not worry then about that. Okay. So the good thing was that you didn't waste any time in, you know, the history palava. Okay. And you got down to the business. I really liked that part was good. Okay. And you asked me about, you know, any worsening in the symptoms and all that. That was good. And what happened then? So when I said, you know, that I don't want chemoradiation, I want all of you guys to remember that when the MDT says that this will require extensive surgery, okay, which I explained. I know I didn't write on it because I was running late for so many things. So I verbally explained to all of you that what does the MDT consensus recommendations, what are they, what do they say? So when they say extensive surgery, then you know, you have to think that it may, you will not say that it will involve this or it will involve this, but what will you say? It may even involve. When the MDT says extensive surgery in the vulval region, what can it involve? Manikam, I want to hear from you. What can it do? What can it involve?
Ma'am?
Yeah.
Ma'am, I do not know anything about the case, ma'am. Just now
so if it's the vulval cancer, if the MDT says that chemoradiation is the preferred option, but you know, if we have to do surgery, then it will be an extensive surgery. Then they don't give you all the details. For instance, suppose this is the information that you have. What is it that you will explain to the patient that when they say extensive surgery, what do you think it can involve?
Can involve
for an advanced vulval cancer, MDT is saying that this, if we have to go via surgery route, this will be an extensive surgery. What comes to mind?
Ma'am, it means that it will involve the removal of the part of the bladder, and the rectum, and the diversion of the colon.
Absolutely, you are spot on, Manikam. That's why I was missing you. Lovely. Excellent. Okay.
Bladder may also be exteriorized, or the ureters may be opened into a small bag made of ileum, which will be opening outside.
Yeah, so basically lots of you know, lots of anatomical changes down below. Okay, so none of you, when I said I don't want chemoradiation, I wanted you to tell me that surgery. You said you mentioned plastic surgeons will be involved. You mentioned things like that, but nobody said that it may mean removing your lower bowel, you know, back passage, removing part of your urethra, and that will mean that you may have to deal with a bag on your tummy for your, you know, you don't have to describe all the ureter and everything to the patient. That's for me, between me and Manikam. She was only telling me as a response to my question. But when you are talking to the patient, he will say that that may mean drainage of your poo and your wee in a bag on your tummy. Okay, nobody said that. And that made me think that if surgery has problems and chemoradiation has problems, then why don't I still have surgery? You kept on saying that because it may involve plastics, but I'm saying, okay, so what plastics? Because you're not telling me what actually is something that will actually be the biggest impact on my quality of life. It's not a removal of, you know, what I am thinking of extensive surgeries. Okay, if the lesion is this much, they may make it this big and remove it, but that's it, fine with me. You are saying that I may need plastics. I'm saying, okay, so what? I'll at least avoid those, side effects of chemoradiation, because you're not telling me a bag on my tummy. You're not telling me that, you know, everything may need to be closed down below. There may be no back passage. There may be no, urethra. So you are not telling me. That's why I'm like thinking, oh, wow. That was my question from you, and you thought this was a good thing that Salma, that when you saw that the consultation is not a successful consultation, it's kind of, patient is persistent in her thinking, then you said, okay, I'll arrange an appointment with a consultant. But that part was good, that if you see a failing consultation, you involve your seniors. Absolutely spot on. But the consultation was only kind of failing because you were not telling me what could have given me a better idea that, oh, I need to avoid this surgery. Do you agree with me? Do you agree that you could have mentioned that, or Salma and Usha, both of you?
Yes, Sam, there is a colostomy also. So I was thinking she will understand this colostomy. It
No,
will be medical jargon.
No, I've not used the word colostomy. What have I just said?
Okay.
Have I used the word colostomy?
No.
No.
Back.
Yeah.
Yeah.
Okay, so
Right.
don't give yourself excuses ever. Just think that you had to give me this information, that this will be an option. You are very good in saying that colostomy is a jargon. If you use the word colostomy, you will have to explain it, what it means. Okay.
We make
It's
it
not
very
always
simple, but it shouldn't. We make it very simple, but it shouldn't, because there is a total abdominal hysterectomy also, bilateral salpingoforectomy, and diabetes, this bowel, bladder, all should be, removed.
Yeah, you will just say that, yeah, absolutely. You will say that it's not only the external surgery, it will be it may need surgery internally as well. And in addition to that, whatever you forget about telling her details of the internal surgery, just say that it will then, for you, what it will mean is that you may end up with then a bag on your tummy for the drainage of your poo and your wee. Okay, right?
And some lymphadenectomy, what we can say, lymphadenectomy patient can understand.
Don't say that, please don't say that to the patient.
No. Just I'm asking for other operation, when you are explaining that lymphadenectomy, how will explain? Patient can understand that remove your lymph
In
node.
most of the cases, you don't need to tell about lymphadenectomy. Just say surgery. In most of the cases, I don't want you guys to talk about lymphadenectomy to the patient. Just say that we will need to do surgery. That's it. Okay, you don't say that. But if you have to say some glands may need to be, you can use the word glands, although they're not glands. but in common language, they can use these kind of words. Okay, but I advise you guys to stay away from these kind of things. These are only foolish and failing things. I won't call this funny, but this will be foolish and failing. Okay, if you started talking about lymphadenectomy to the patient. Okay,
No, I'm not asking this patient. As a whole, lymph node patient can
I'm not
understand lymph node?
telling about this patient. I'm saying a rule in general. If you are able to absorb that, okay. I'm not saying about this patient. I'm also talking about general. Okay, so don't try to tell these things to the patient. Just say it's surgery. Okay.
Okay.
All right. So no, don't worry. You don't need to talk about those details. Most of the cases, just try to stay, most relevant things that they understand. Okay, like they will understand if you said uterus, they will understand like womb, if they'll understand if you said ovaries. So things like that. If you wanted to tell them that your kidney may have to be removed, you can say and they will understand. But don't try to talk about ureter. Don't try to talk about nitty-gritty of stuff. Don't do that. Okay. Right? So what did Usha do then? So let's come back to, oh yes, when you Salma, when you were offering me appointment with the consultant, and I kind of mentioned that this is very difficult for, and you said, yes, I understand. I think it was you, isn't it? Because I've written that what you could have done here is you could have said that you can bring I know this is difficult, too much information, difficult decision. We don't mind if you wanted to bring a family member with you, like your son or your daughter or your husband with you when you're meeting with a consultant. That may make it easy for you to make a decision, okay? Because this is what we do in the clinic. When we see such a patient, we encourage them to bring a family member with them if it's difficult to understand, or decide, okay, the options, right?
Thank you for feedback and give me opportunity. Thank you.
Thank you, Salma. And Usha, what did you do? Where are you, Usha? Okay. Usha is here, yeah?
Yeah, just, yeah.
Good. So Usha, you seemed to be starting, you did the very good thing with a very good agenda and all that. Okay, introduction was good. You asked me if I was alone. It sounded more like if you are, first I thought you were talking about, BBN, like you are breaking bad news now. But maybe you were saying because the options that you would be giving me would be probably difficult for me to handle.
Yeah.
This is what I said to Salma as well. Was it the reason that you were asking? Yeah.
Yeah.
So if something like that is in your mind, it's always good to say that we can discuss the options. It may help you better if you have somebody with you to help make up your mind and understand your options. Do you have somebody in the waiting area that you want to bring in? So what you're trying is that I'll be giving you options, and to decide, it's not always easy. So you can, if you are allowed to bring in somebody, so they can help you with the decision making. So it was that, yeah, that part was good, but just explain a bit more. Otherwise, I'll be thinking that I already know the diagnosis. So
No, because I was thinking decision making, they will help.
Yeah.
So I should make it clear. Yes.
Yeah, it would be a good idea to say that you'll probably feel more supported in making
More
your
supported.
decisions if you have somebody with you. Do you have somebody with you? So that makes it very clear. Otherwise, I am listening to you and I know the station. Still, for a second, I thought that, is she trying to do a BBN here? But then I thought, she's giving me opportunity to, make a, to facilitate my decision making. So I could get that, but it will be good. It will probably not be counted as any mistake or anything, but it will be very good for your communication, that you were so clear with your communication that she didn't think twice that what are you trying to say. Okay. So this is just like an extra tip. Okay. You said the word team has decided surgery and
it's MDT. So
yeah, MDT has decided. So I would encourage you guys to not say the word decided, say recommended.
They recommend.
Yeah, decision will be hers. Yeah. So you say that
Okay.
MDT has given their consensus on recommendations, or they have made their recommendations. Okay,
Okay.
that will be better.
Okay.
And yeah, please just be very careful where you are offering examination and why. Okay. So if this examination part was
No need.
absolutely unnecessary and all that. Okay. You can ask that any problems with the biopsy wound, has it healed fine? Do you feel any pain and or discharge on there? So you can ask that, and if she says that yes, there is, then you can say, do you want me to examine you from there again? Okay.
Okay.
Right? So you can offer. Otherwise, just don't say that, you know, I'd like to examine you. Patients can, if it's unnecessary examination, they can say, why do you need to examine me? So role player can say like that if that's an unnecessary examination. Okay. Now, you said, yeah, so yeah, don't try to give those time frames. You put your foot in it, and I enjoyed dragging you. Okay. Right? You said 60 or 61 days.
Yeah,
Or
I know. I just then.
Yeah,
should
don't
not give
avoid
numbers.
specifics. Avoid all the specifics.
About
Okay?
yeah.
Okay, because when you go into specifics, you put your foot in it. You
Yeah.
you do mistakes. Okay.
Yeah.
I have, you know, whenever people are thinking that this information is a must there, I have avoided so many times all the information, all the factual, you know, things there, just because I didn't want to do mistakes, or you know, you should know the tactic to go general. All right.
Okay.
Okay. Use the word may, maybe use the word significant, or, you know,
Okay.
minor, rather than the percentages. Only talk about very few very important percentages when, you know, like consenting for a C-section, and you know, those kind of percentages could be important. So just those kind of. Otherwise, try to avoid specifics, so that you are and you can, again, you also can offer an appointment with the family if you think that the you know, there's any problem in making decision. Okay. But the problem was basically because both of you didn't mention, I mean, poor Sidra, she didn't even reach that point where I would be able to say whether she mentioned or she didn't mention the you know, detail of the surgery. So she couldn't reach that point. But you guys had lots of time, and you guys, you know, kind of, I don't know why you avoided. Did you forget, Usha?
No, actually, I think explaining was
You can
difficult.
always say maybe. Okay.
Yeah.
There may be a need. So I always say to all my students that maybe is quite a rescue word, because you can say things without the fear of that this could maybe not apply in her case. Okay.
Yeah.
All right. You can say it may require extensive surgery in your case, and, you know, or you can say they have said that it will probably require extensive surgery in your case, which may mean that, you know, part of your back passage may have to be removed, part of your, you know, urethra and bladder may have to be removed. And whenever you say urethra, immediately check, do you know what urethra is? Okay. Whenever, because this is slightly
clear every part. Yeah.
I think most of my patients know what urethra is. Okay.
Yeah.
Most of my patients would know. Okay. But you can just clarify, just for the purpose of that, you know, they're not, you know, they're not thinking that you have not used a jargon or something. Okay. I don't consider urethra a jargon. I think I would have said urethra in my exam, really. Okay.
Okay.
So is it clear?
Yeah, definitely.
Now, anything in this one, and do you think next time you guys can do this, you guys can nail this station? Yeah.
No, quite clear. Yeah.
How would I go about it? Just ask few points in the history. What you want to know is the itching with which she presented, you know, how is that? And Salma asked that, and did you ask that as well?
What?
Yeah, I asked Ichi.
Salma, I remember totally. But Usha, did you ask as well about the itching?
No, because you already say, I said, how have you been doing since then you said, yeah, some itching, and my doctor gave.
Yeah, I said to you,
So
yeah.
that is why I did not repeat.
That's fine. Yeah,
Yeah, but only what I'm trying to say is that only symptoms that are important are that the symptoms with which she presented. Okay, how are they? How does she need help with that now? And then the next thing is that that could, so symptoms of a cancer could be good if you asked. Okay, if you asked me, you know, how have you been, like you could ask how is your general well-being, how are you generally. If I said I'm not able to sit, stand, I feel very weak, I feel, you know, I just want to lie down all the time, then you could start thinking of fatigability and all that, and you say that, okay, I need to mention that to the MDT as well, so that they can you know, address that, okay, for you. Okay, so like significant weight loss and anything patient points out, you will make sure that you don't walk by her symptoms. Never walk by the symptoms. Yeah, if she tells you a symptom, you say, yeah, okay, and then you ask the next question.
Yeah,
Don't do that.
one more thing, like a weight loss, loss of. We have got diagnosis. Do I need
You
to ask?
have no.
That's
What
why I
I'm
just
saying
want to,
is that you have a diagnosis now, so
yeah, then
not,
this
you
will
don't
not
need
go.
to make a
Yeah,
diagnosis
it's
now.
over.
You're just thinking that how's she doing generally. So
How
that's
she's
why I
doing
said that you
generally,
just say, how are you doing in general, like, you know.
generally.
So if
One
something
thing,
is bothering her very much, then although that was a diagnosis, you know, part of the making diagnosis and all that, but that is something that's still bothering her.
Still
We're
bothering
not
me.
thinking in terms of making her
Okay,
diagnosis. We are
yeah.
thinking now in terms of helping her, isn't it?
Yeah.
Right? So
one
just
thing I want to ask, Hussain, should we use the word of MDT to the patient?
yeah, because we would have informed her, so it's not like you can say MDT when, because she is
Explain.
there for the MDT report now. Okay, it's not
Yeah.
the first encounter. She is there for the MDT report. Yeah,
And if the patient has come
and
for
you
the
can
first visit,
explain. You
like,
can you know what MDT is. Yeah,
yeah,
if you ever have a doubt, just say MDT and say, you know what MDT is. It's a group of the specialists who made this, just, you know, made recommendations for you, the cancer and all those doctors. Yeah. Is it Biba who's asking?
okay.
Who asked the question?
The question.
Sidra, I asked.
Oh, Sidra, it was you. Sorry. I didn't recognize. Okay.
Yeah.
And so, okay, yeah. So do you see that MDT, because she is, look, you have to always remember, you have to place yourself in time and space. Okay, situational awareness. What's your situational awareness here? That she came first, she was referred, biopsy was taken, then she had an appointment where the biopsy result was there. Somebody would have explained the result and said, we are now going to refer you to the Gynae oncology MDT. They would have explained what an MDT is. Okay.
Okay.
Right. And now she's here for the what the MDT has said. So now it's not a jargon. At this stage, it's not a jargon, but if you are worried, you can always say, you can always double check. You can say that, you know, you are here to see what the MDT has decided. And if she says, like, Doctor, what MDT? Okay. Then you can say that were you informed that this was to go to the group of specialists who will look into this, you know, and then you can explain what the MDT is. Normally, by this stage, you would know what an MDT is. Okay. And if you thought that if you said this, they will count as jargon and they will correct that, they will count as that you explained on asking, then okay, just say that, you know, the cancer specialists who had to make decision on that, you know, the MDT doctors. So you use the word together so that you can then use on its own as well. Okay. So in the first use, you can explain, you know, the MDT, the specialists who had to make this recommendations on the treatment, and then you can keep using the word MDT. Is that okay?
Yeah.
Thank you, Sam, to
Okay,
give
Salma,
us
thank you.
nice.
Any other question from anyone before we go?
Yeah, Sam,
Thank you,
you
Sam.
have valuable time. So thank you. That some issue you explored here, that which and first one is you told that if already given diagnosis, so no need to go back. Yes, this one that, like, you know, if stress urinary incontinence given. So I'll tell related to the stress urinary continence, the question. Yeah, like anything, if it is diagnosis given, I'll tell related to this diagnosis only.
Yeah, you will
No
say
need to,
once the diagnosis has been made and there are no associations that need to be
Yeah.
ruled out, then.
yeah.
Okay.
Because do you think that we have to tell the differential diagnosis to exclude this? Because already diagnosis given, isn't it? Differential diagnosis, no need.
See, what happens is that with stress incontinence, because normally, yes, but with stress incontinence, I need to add one thing, okay? That with stress incontinence, the mixed can coexist with stress.
Yes.
It's good to ask urge as well again, because she might have recently developed urge as well, okay? So
Yeah,
it's,
this one I have to, but something like, like polycystic ovarian syndrome. If I'll ask that PID, was the PID already diagnosed? So do you think I can ask?
I in the last session, I don't know if you, I think you were there in the last one when I said that, when the patient is referred for suppose secondary amenorrhea, they did the investigations, she was hyperprolactinemia, then and they said normal thyroid function test, then please don't go back
Yeah.
and start with trying, causes of secondary amenorrhea, because they
Mm.
have given you something. So start from that point, yeah?
Yeah.
So you're
Yes.
right in that, yeah. Absolutely.
Yeah, thank you. Another thing that HRT, which one you mentioned. So HRT, do you think when I did the clinical assessment, I saw that, the trainee, they are writing for the giving advice for that. So what my understanding that if there is a
Sorry, I
any,
didn't get, I was reading something, Salma. Can you repeat the question?
that HRT, do you think that we can prescribe, or I can tell if there is any risk factor like she's history of BTE or breast cancer?
Salma, did you hear that I didn't even say anything? I said you should be seen by someone in the menopause clinic, okay? So we don't try to be experts, okay?
So that means we'll refer to menopausal clinic.
Yeah.
For HRT.
Yeah. If the question says that the patient is there, like assuming that you're probably sitting either in the menopause clinic or the gynae clinic is dealing with this. Gynae clinic also deals with that, but that will be if the main station is menopause, then you deal with it, okay? But then you won't say, okay, I'll refer you because that station is menopause. But here,
No.
menopause is coming as a tributary of the problem. It's not the main problem. You will leave it because you don't have time to start talking about the management of menopause there, okay?
Yeah. No, if I'm gynae clinic, say for example, I'm seeing for another reason, like maybe
Then say menopause clinic, okay?
Okay.
Okay, Hafsa, what was it? Hafsa is asking if the patient asks, can she start treatment? What do we
Thank you.
say that the treatment will be started at the earliest, and once you have made the decision, that decision will be conveyed to the MDT, and the cancer nurse will contact you to start the treatment, at the earliest. Okay.
So another thing that BBF that to see there is a.
Salma, could you hold on, please? Hold on. Hafsa, are you still here? Hafsa?
Yeah, I'm here.
Okay. Did you get the point, Hafsa?
Yes, I get it.
Okay, good. Yes. So, okay. So what was it, Salma? You were asking something.
BBF, there is a, 3 swab test. Yeah. So still it is, they do in the clinically, or there is a double test. There is a something double test.
Salma, you just say 3 swab tests. That's fine.
That's it. Okay. And another thing that for PET, that junior, that teaching station, there is a one recall. So do you think on that cases, we have to explain about the preps and priors that they do for the risk prediction? We have to explain
this to the
junior.
So you will only explain whatever few words are written in the guideline. Okay, you don't really need to go into because otherwise there's another link that allows you to read what actually those two are. Okay.
Right.
So whatever's mentioned in the NICE that there are some methods that are used, just say that. Okay. And you say that those tools are available on the internet. Say NICE guidance has the link to those tools. Okay.
And do you do this hospital that in the routine cases, that if PET case?
We some people like to do it, some people don't give much attention. Okay, so you can say, when you're teaching, I always say, with all the stations and everything, you need to be very flexible. Just say that there are some tools and the links of them are in the NICE guidelines that, you know, that for that risk assessment. Okay.
Mhm.
All right.
Right. Other things that, you know, blood group and blood transfusion reservation, these things, blood
Okay.
group and blood transfusion, this
Okay.
is and reservation, we need to explain all antenatal case.
We need to do what?
We need to ask the patient in history taking for all antenatal case, blood group, blood transfusion reservation.
Okay, so we have talked about this quite a few times. What happens is that when the patient comes for booking, then, you know, people ask because their documentation has to be done. And actually that's really usually the midwife who asks. Okay. So for us, it's more important in terms of scoring any marks. It's more important when we are talking about mode of delivery, or, you know, when we are talking about, say, you know, deciding between when she's nearing her term and we are expecting that now it's more relevant. Booking history actually is asked taken by the midwife, but if she is coming for the first time and you are doing the booking history for whatever reason, okay, no harm. Early pregnancy, no harm in asking. But ask, you can always, with these questions, the trick is always that you don't spend too much time. Just don't ask blood group. Never need, you don't need to ask. You can, you know, you can ignore that question. What's your blood group? Okay. Just ask about the reservation to blood transfusion, because most of our patients are not aware of their blood group. And I think, Salma, we discussed this before as well. And you said, yes, I think that patients don't know their blood group, and you've forgotten. I saw something from Biba.
Thank you.
Biba, sorry for joining late. I know what the question, the last one. Are you asking what was the question, Biba, that we discussed, like the main question of the day? Yeah, the station.
Yes, the cancer one, which you were discussing when I joined.
Yeah, so we only did one station, 3 people did it. Okay, so this is what we usually do, isn't it? So the question was that, let me show it. I haven't written the full station here, but have a look. Okay.
Thank you very much.
Yeah. And I said that the, what's that, MDT has given their recommendations, which I didn't put here. Okay. And I verbally informed them that they have said that chemoradiation is the preferred option for her, because if the surgery has to be done, it will be extensive surgery. Okay. Because the lesion is in the midline, and because it extends to her anus and to the front up to the urethra. So this is, I verbally said that this would be the case. Okay.
And if she doesn't agree to chemoradiation, then?
So for that, you will have to listen to all that we said, but I'll quickly summarize that whenever she doesn't agree, we need to first, as we do know in general, that we need to find out why she doesn't agree. Okay. We need to explain the differences, and, you know, the location of the of her problem, where the where the radiation was done, the type of the chemotherapy that was done, say that it would be different and it would not cause the same problem in all the patients. So patient to patient variations are, variables here are patient, individual patients vary from each other. Variables here are the type of the chemotherapy that will be used. So all of the chemotherapies don't have same side effects. And then the difference here is the site of the radiation as well. So reassure her that that is what your friend had is not what necessarily you will have. Okay, one thing. And then you'll say that there are measures that we can do to support, and you will say that we will respect your decision. Finally, it's your decision that we need to respect. Okay. So if she wants to do whatever and you think it's not a good choice, you need to remember the principles of mental capacity. Okay. If she has mental capacity, she has autonomy, right?
Yes.
Yeah.
Yes.
So you don't forget that. You don't,
Thank you.
you have to have in your mind that if she has capacity, she has
autonomy, that means that you just, once you explain the surgery to her, the surgery is so extensive, it will remove this, it will remove this, will end up in a bag on your tummy for poo and wee, she will be convinced. Because at the moment, as a patient, I'm thinking that it's only a small lesion. Okay, why don't you just remove it? Okay.
Mm.
So you have to understand patient psychology. We don't, I've seen, okay, girls, all of you, my very, very dear girls, all of you, please listen to this one as well. I've seen so many people who quickly surrender to, like they say, we will respect your choice. Okay, but that's not the right thing to do, because you have to make sure she's fully informed before you say that is her choice. Okay, what are the principles of consent for anything? They are mental capacity, fully informed decision making, okay, and then without coercion or pressure, okay, free will, right? So if you haven't done the fully informed part of it, then it means that the consent is not valid for any treatment, whether it's implied consent or written consent or verbal consent. You need to make sure that she is aware. So please don't quickly say, yes, we'll respect your. So I've seen so many people do that. Please don't do that. You have a job to do there. I mean, she's saying that, no, I want that. First, try to explore why. Think, why would she say that? Think. And then, okay, does she really understand what it means? Okay, then explain to her. Once you are sure in your heart that there's nothing hiding from her, she knows everything and she still wants this, then you don't even need to ask me that what do we do, because you know she has autonomy. Okay. Yeah.
Yes.
Good.
Very nice. Thank you. I never thought this way. Now I'll
I think it's because it's you guys are having an exam and you're stressed. Linking, the linkages that we make in our, the associations in our head that we make, that can become weak when we are stressed. Yeah.
Yes. Thank you. Thank you.
If patient will ask, doctor, will I die?
Oh, that requires one full session, Salma. Shall we leave it to the next session? Will I die? That is an important question. I think I have addressed it in the past. I think Salma you might have listened to it as well. But if you are wanting to
No,
ask that,
I didn't.
that's a good question, very good question. But either I would have shared an audio or I'll discuss it in the next session.
Okay,
but
thank
before your exam, inshallah, definitely before your exam, we'll discuss this. Okay.
Okay,
If I forget, just remind me after 8 days if I forget. Okay.
Thank you very much, Sam. You told that consent, about the consent, that's cesarean section. So do you think that all consent, the percentage we have to memorize that percentage? Which one?
No, just listen. Most important and most frequent few, if you know, that should be sufficient. I've always been an enemy of the percentages. Okay. Whenever they ask me some percentage, if I have an idea, if I have a very good memory, then I'd say it may be this much. And I always use the word around this much. But if I don't have an idea, I could say it's not very common. Like I use vague words. Okay, then very vague words where I don't get trapped. Okay, so using vague is much better than being specific. And you can also say it's not on the top of my mind, but I can find out for you and I can give you written information. That saves you. Okay.
This is like junior.
Yeah. So what? Even junior.
Okay.
So what? Say I don't have percentages on the top of my mind, but if you're doing a consent, I'd encourage you to read the RCOG consent advices. That has got the best, details of the relevant percentages that you'll require for the consents. That's it. You don't need to memorize. Okay.
But anything that it is simple, but we should know that. Can you give us idea?
Something that's very simple is good for you to know. Like I would encourage you to know the consent advice figures of section and hysteroscopy at least, if possible, laparoscopy, just these three. Okay.
With percentage. Hysterectomy also? Hysterectomy? No?
I won't do that.
Okay, probably if I have to, I'll probably go with evacuation, because evacuation comes
Yeah.
in, you know,
Yeah, yes,
evacuation.
evacuation.
Not hysterectomy, no.
And
Okay.
some we have face-to-face exams. So do you think that manual vacuum aspiration, Marina, and so many things that all we have
Look,
to
Marina can come. MBA, probably. Is it difficult?
part
MBA?
2 gram? No, we read before, but nowadays
Just revise it. Yeah. Revise
yeah.
it. It's better. I don't want to be reassuring you that maybe it's not coming in the exam and then it comes and you say the same.
No. Yeah.
It's small.
Electrosurgery.
Like, okay, one more thing is that please, you don't have to know the nitty-gritty of anything that you're teaching. Okay.
Mhm.
You need to learn the trick that without talking the nitty-gritty, how you
Yes.
cover the station. Okay.
Yeah. Electrosurgery also. Electrosurgery.
Elective surgery.
Electrosurgery.
What
Monopolar,
elective
bipolar.
surgery?
Yeah.
Yeah.
Monopolar,
That can
bipolar.
come as well. Yeah. RCUT likes it.
Yeah.
I don't like it, but yeah,
Yeah.
they like it.
We don't like also.
If I made the exam, I would not include. I could probably ask like 2 or 3 questions, but that machine.
The coupling, that one coupling capacity. So coupling capacity, that one, as a whole, general idea, what I know that if you use that plastic and metal, trocar same time, then there is a risk of burn more. So it should be all metal or all plastic. But there is this other person, they are explaining different way, but I feel this one is more easy.
Look, a coupling is not just one type. Coupling is capacitative coupling and then some other coupling as well.
This one,
And
yeah, direct coupling or capacity
direct,
coupling.
yeah. Okay.
Direct
So I would
capacity.
say just a couple of paragraphs from strategy, and get it from strategy. Just that paragraph. When you say that one person was saying one thing and the other person, I just say go to the source. Okay. So strategy has the best one. I don't remember on the top of my mind about that one, but I know there are these two, and these are,
Yeah.
as I said,
Yeah.
I don't like.
Yeah.
Basic practical skills. That is
Basic.
very good book. Basic
Oh,
things are only there.
Basic practical skills of RCOG, yeah? From
Yes,
RCOG.
yes.
Yeah. It's a very good book. I
Yeah,
like
there is-
very few books. I like the prompt manual, the MOIT manual, and the basic practical skills. All these 3. These are very good ones.
Yeah, and
Must
not
be.
tie. Do you think not tie?
What's that?
Not
Not
tie.
time.
I'm not able to comprehend.
Not tying.
Not time.
Tie.
Tying, not. Oh God, okay.
Not tie.
Tying. Okay.
Yeah.
That can come in the exam. Yeah.
Yeah.
Now you have face-to-face exam. I'm so lucky that I had online exam. I liked it. I first
Yeah.
thought I'm not going to like it, but I really liked it.
Yeah.
I first thought that no. Tone of voice in cancer station. Who is this?
Yes,
Rita. Okay.
yes. Yeah.
Tone of voice.
I'm very blunt.
You tell me. You tell me. That this is a basic thing. You tell me. What should be the tone of voice?
How are you today? How are you coping with your illness?
No,
Can-
this is
can
too Nah. This is you're too joyful. Okay.
Yeah, I know.
Okay. So
Hello.
exam is face to face or
Face to face.
okay. So you would be okay. Okay, because
Yeah.
when we are talking and sometimes our voice is a bit more jolly, joyous,
Yeah.
but our facial expressions are supporting the empathy. Okay, so that would be probably better.
Some
Okay.
another thing that and risk management, that investigation, is it 61 days risk management.
Why are you asking this? Where are you going to quote this?
This is junior. There is a structured discussion one risk management. That near miss. So that one you have to explain.
Okay,
that.
you don't need to tell them in exact number of days.
No need.
You just say that there are time frames that we have to follow.
Okay. According to
Okay.
the
I
protocol.
told, look, girls, look, listen, all of you, please. If you don't listen to what I say, then I feel that I'm not really doing the job there. Then I say that, okay, because you guys keep on coming to specifics. I am requesting you guys to avoid the specifics, okay? Give yourself that break. Okay, try to avoid specifics. Use the broader words. There are time frames that we have to adhere to. Okay, they're not going to fail you because you didn't say how many days.
Okay, thank you. We are struggling with this. Thank you.
Because you are, okay, a few of you, and I hope it's not you, Salma, few of you will struggle because they are very, very clingy to the nitty-gritty. And if you do that, you unfortunately will have loads to, you that you think you know, and you then get surprised that why I didn't get that many marks. Okay, because that's useless information for OSCE. Okay, in OSCE, they're not wanting to know the things that they will be probably doing. You could do in an not even, they don't even give such things probably in SBAs now. Okay, but if they could check you in SBAs for those things, not here.
Okay,
OSCE is
thank you.
not for that. Okay, so don't burden yourself with. Otherwise, you keep feeling depressed that, oh, I didn't get those many marks. I knew so much. Okay.
Yeah, thank you.
Don't do that with yourself. Okay. Okay, girls, anything else, or should we call so Shazia Sadruddin? Hi, Shazia. I've never seen you. Hello. Okay, so we have a Shazia here. I was just trying to welcome her because I have never seen you before, Shazia. So, okay. Okay, girls, is it time to say bye then? Yeah. Okay,
Thank you very much.
please, I have a question. Yes, thank you,
Yeah.
Salma, for joining.
We feel better to talk with you, really. We feel better.
I am happy. So Hafsa's question I'm trying to read. I have a question concerning the third line management of bladder pain syndrome. Are they injected into the bladder wall or as fluid into the bladder? Is there a frequency of repeating it? Okay, Hafsa. So that these things are instilled in the bladder. Okay, so not in the bladder wall. This is very clearly given in the bladder pain syndrome green top guideline. Okay, and you really don't need to know the frequency of repeating it and don't need to tell this to the patient. Right, Hafsa?
Okay, thank you.
Okay, so avoid nitty gritty, avoid, just say that that will be decided when we reach that point. Okay, no commitments about frequency, no need to be that specific. Okay, but yes, these are there are some options of some medication available that can be instilled in the bladder, okay, for the treatment of this syndrome. Okay, girls, any more question, or shall I just call the day? Okay. Yeah, no more questions.
Have a nice weekend, Shem.
Sorry.
Have a nice weekend.
Thank you. We are traveling. We are very busy over the weekend. Thank you. You guys have a nice weekend too. Okay. Bye-bye.
Thank you. Bye.
Bye then. Bye.
Thanks.
Bye, everyone.
Bye.